I used to laugh when the old guys get up and they say, well, back when I was doing all this stuff, that this is, how it was. Well, I'm looking around and I'm one of those guys now. So it's been kind of fun over the last 45 years to see how things have really changed. And so I'll give you my perspective. The disclaimer is my perspective. It's based on some things that over a period of time that we've been able to do. And it's fun to see how you've changed over the years just with the data. And that's the beauty of science. As we gain data, we have a tendency, if we're really open, we change and use those new techniques. And so I think that's what I would like to impart to you, is that just because we're doing it today doesn't mean that we're going to be doing it that way in the future. So I'm going to look at the concept of thoracolumbar burst fractures. Let's start with the classification. We humans really like to pigeonhole things. And so, we talk about a Glasgow, the coma, with the traumas, the coma, all of these things. We have put numbers on it, Schatzker, classification of tibia fractures. So we really like to pigeonhole all of these different items. But classifications, other than just being able to talk to one another about things, they should have a purpose. And that purpose is does it give us some benefit on how we manage the issues? And so that's what, over the years, we've been able to really change our classification of burst fractures. When we look at that, it gives us the ability to identify the injury, look at the severity aspect of things, and then guide the treatment and allow the audit. In other words, is it repeatable on what we're doing? And I think this is the real important pattern when you're looking at a classification system. Does it offer a benefit to the patient on the way that we manage things? So it should have a logical structure, should be comprehensive, should be hierarchical. In other words, from easy to hard or simple to complex. And then also should be as simple as possible so that everybody can really fully understand on what's needing to be done with that particular fracture pattern. So from the spine standpoint, we really need to know, is it stable or is it unstable? Can the patient get up? And we talked a little bit about that last evening with the different presentations that we're having. No neurologic, no late deformity. And then the beauty from the pathoanatomical standpoint is it a mechanical aspect that can be reproduced. Because a lot of the times when you're looking at a fracture, the way you reduce it or the way that you take care of it is you reverse the mechanics of what caused the fracture to happen in the first place. So when you look at the classification of burst fractures, started in the 30s with Watson and Jones, and then progressively over the years changed. And I'm putting my career started in 77. So I've been through the Denise, the Ferguson Allen, the Mogrel, the TLIX, and then the spine injury score program. So this is all of the classifications that have taken place during my particular career. And the reason that they changed is because we were much, much better at gathering data and much, much better at documenting how we treated this thing. So it's going to be very interesting in the future how this progresses from, 2025 on. So a lot of you young guys will be, 40 years from now saying, okay, yeah, McGuire said this, but he was a little bit outdated at that point. That's okay. That's the beauty of the of what we're doing here. So when you look originally, we had a two-column situation, basically an anterior column and a posterior column. And this was anatomically based and from the concept standpoint, because that's the way the spine is designed. Denise came up with the idea, okay, there's a three-column here. We've got a middle column. And so let's put that into play. Okay, how does this change our classification system with that third column in place? And so now we're looking at basically the posterior aspect of the disc, posterior longitudinal ligament, and those structures within that environment. the retropulsion of the bone, et cetera. And then, of course, the posterior column is still the same. And this is really conceptual rather than anatomic, because there really is no middle column when you think about it anatomically. And so it's based on really the biomechanical studies on how those ligament and bone structures interact with one another during the mechanics of a fracture. So when you look at the classification system, he had the compression fracture, he had the burst fracture, he had basically the distraction injury, the seatbelt injuries, and fracture dislocations. The problem is it's non-hierarchical, and there was no relationship to the stability. So it really, even though you're classifying these systems, it doesn't give you any concept on maybe how to manage these things. So then Mogrill and the AO group came together, and they started looking at the AO classification, which is a simple, straightforward ABC category. And it uses the same concept of that three-column particular injury where you got an anterior, posterior column. And so if you have a fracture of the anterior vertebral body, that's an A. If you develop a posterior aspect, whether it's going to be soft tissue, whether it's going to be bone, that falls into the B category because you've got a distraction phenomenon that's going to tear those tissues. And then if you start rotating this, that becomes a C. So when you look at the soft tissue aspect, the disruption of the disc and the ligament will actually go into the posterior column aspect of things, and it still puts it into that unstable category. So when you look at the neurologic deficit, again, it should be hierarchical. And so the AO classification, it does seem to increase from a logical standpoint. In other words, the A fractures, less common with neurologic problems, the B increases in the C. So it's a progressive situation, so that the more severe the injury, the more likelihood you are to have a neurologic deficit. Stan Gertzman looked at the concept of the Nice classification, and it really didn't correlate well with the standpoint of hierarchical nature on this, even though it was a little bit unique as we were going through from the biomechanical standpoint. It just didn't seem to fit that pattern on the hierarchical nature of the process. So again, with the AO classification, we look from the standpoint of stability, of instability, or are they stable, or is it unstable? I mean, it's pretty simple questions that you ask. And so when you look at it, there's that in-between category. So your A's are usually stable, your B's can be stable or unstable, and then the C's, they're unstable. So it makes perfect sense when you're looking from the standpoint of the hierarchy on how these things progress. So how do we assess it? Okay, we look at the anterior and posterior column. Pretty simple, straightforward type things with standard radiographs, CTs, and MRIs. Does it fit the system in looking at the fracture from the standpoint of radiology, that it would fit in that category? And Owner and his group showed that. Yep, you can look at a CT scan, and the category fits pretty nicely into that category just with the CT and the radiographs. The MRI comes along, all of a sudden now you can look at the posterior soft tissue structures, which then adds the category of your C, and that's kind of steps us into the next direction of the TLEX program. And so now we're looking at not only the mechanism of injury, but the neurologic status and the posterior structure status. And so the spine study group looked at that particular progression of symptoms, and as we see, started adding numerical factors to these particular items. And with the idea of being the more severe neurologic, the greater the point value is assigned, so that can you use this category to dictate the way things should be treated? So certainly looked at it, and anything less than 3 probably could treat conservatively. Anything greater than 5 probably should be considered surgically. And then we'll go a little bit further in just a moment on, does it dictate, do you go anterior or posterior? So when you're looking at things, and we saw yesterday in that discussion, these are guidelines. the beauty of what we do, it gives us a basis on what to make our decision on, whether you go anteriorly, whether you go posteriorly. There is no true right or wrong as long as you're using a logical progression of your thought processes and how to manage these conditions. So you've got 3 questions to ask yourself when you look at any of these fractures. 1, surgery, no surgery. Anterior, posterior, they're combined. You know, everybody says, oh, you're a spine surgeon. That's really a complex business that you're in. Well, it's really pretty simple. I mean, when you break it all the way down, we're not in a black box. I mean, we're making decisions on things that are in front of us, and it's pretty simple, straightforward if you pay attention to the details. So, old school, when I first started, we laid people in the bed for 3 months. And I don't know if any of you have ever seen one of these rotor rest beds, but we had people rocking and rolling at the Naval Hospital for years, and those open bay wards that we had, we'd have 4 or 5 of these things the whole time. It was really good because it minimized the risk of soft tissue injuries. And so you didn't have the bed sores that we used to have when you just lay them in the bed and nurses would come by and roll them around. So that was one of the progressions that I was able to see just with conservative management. So you keep them for 6 weeks in the rotor rest bed, then you stick them in a plaster or plastic jacket, and for basically a total of 3 months. And then some of those did go ahead and collapse like we were talking about yesterday. So when you look at the development of instrumentation, we went from basically rods and hooks. We went to the Luque system, which was sublaminar wires and straight rods. And then we add a hook and a rod, so you go the Harry Luque. And then Edwards came along, put a sleeve on this thing so you could get your 3-point bending, and everything is progressing. And then all of a sudden, a pedicle screw came out. So in the early to mid-'80s, pedicle screws, the CD system became available. Then it started with mainly deformity, but then we'd say, hey, you know, this is like bridling a horse. I've got a system now that I can actually grab the spine and control rotation as well as flexion and extension. So then the attorneys got involved in the early 90s. We had the pedicle screw issue because they said this is going to be a huge deal now. Everybody wants to get a little bit of extra money with this thing. And so it became a huge legal issue. We've got one of the best things in the world to be able to manage spine fractures, and now it becomes a legal issue, and people are starting to get afraid of it. Well, fortunately, we kind of had a bunch of us got together, and I remember being in a court in New Orleans, and the judge says, "Doctor, do you understand what contempt is?" And I said, "Yes, sir, I do." But I said, "I thought we were here for the truth." And he says, "Just answer the questions that you're asked." I said, "Well, yeah, I'll be glad to answer them." But I said, "They're taken out of context." And he goes, "You remember what contempt is?" I said, "Yes, sir, I did." And so at that point, it became yes and no from the questions. I didn't want to spend the evening in the jail in New Orleans. So it was, but it got really contentious, and fortunately, we were able to reconcile that. And then, so with the Steffi system, that comes out, then we started looking at anterior. We became really biomechanically more in tune with the structure. Can we reproduce or reconstruct the anterior column and maybe get away from even messing up the posterior column at all? So we developed these anterior instrumentation systems, and now as I backed out of the system, we were starting to do far lateral decompressions and percutaneous fixation. And it's going to be important, and we'll talk about this. These are our constructs that you look at. And why do you go 2 up, 2 down? Why do you go 1 up, 1 down? Why do you go anterior and 1 up, 1 down? It's got beautiful biomechanical reasoning behind what we're doing. So we're making progressions on how to address these fractures depending on the data that we have. So when you look at biomechanics, we've talked about, and we'll talk a little bit about neurological stuff, so I'm not going to get into that. But the big thing that we're looking at is biomechanics. prevent the correction of the late instabilities, and provide a stable construct. Neurologic, we've got some beautiful studies that are suggesting it used to be, do you operate on them immediately? Do you operate on them a week down the road? And as I said last night, if you put your finger on your eye and press on it, that starts hurting a little bit. Well, what's the difference between an eye and a spinal cord? Not a whole lot of difference. I mean, a nerve's a nerve. So it seems to me, from a logical standpoint, the sooner that you get the pressure off the nerve, the better likelihood you are to have an improvement in those symptoms. So that just makes sense. But it's very difficult to prove these things because of the studies when you start looking at the cost involved in a study, and how do you put people in a random selection if you're thinking, I really need to operate on this guy quick. Why should we? There's a lot of issues that come into play when we're designing studies on this. And so, but it does seem to be that the sooner that you get the pressure off the nerves, it does get better, but it's not exact. So if you're a late decompression, early decompression, ultimately there is improvement down the process. So the real key, I think, is to get the pressures off the nerve. So when we go back to that TLIC system, does it give us some ideas on how to approach? And so it really does. If you look at the neurologic status, if they're intact, as we say, stated before, with those A fractures, hey, you got an option: conservative, surgical. And if you've got root injuries, decompression, and where you have the real issues, or whether you have the neurologic deficit with instability, it gives you the ability to go front and back, or front altogether. So the system is giving you some ideas looking at the neurologic status. So when we look at the A fractures, we talked a little bit about that, and as they progress, and most of these you can treat simply for the fact of the deformity. And if it's a significant kyphosis, and what is significant, I like to use a 25-degree category and then 50% loss of height. And we had that one last night that we were talking about with contiguous fractures. So there are some issues that are still there. And so what's the acceptable deformity? Like I said, I like the 50% loss of height in the 25-degree. And if it starts getting into that pattern, then you start considering doing things from a surgical standpoint. We did a meta-analysis of, and I alluded to it last night, was looking at A3 and A4 fractures. And there does seem to be a regional, pattern. Some of the regions are more aggressive in their management of these things, but the outcome, whether you treat it surgically or whether you treat it conservatively, seems to be very consistent. And so you kind of pick and choose as to what you want to do on this. So the B categories, look at basically the anterior column, and again, the correction of the deformity, the stabilization of the instability. And when you look at this, we know that if you don't have that anterior column, if you think about it, I don't have a bridge up front. So if I'm putting instrumentation in a level up and a level down, I'm standing on a diving board and I'm bouncing. I'm putting cantilever bending all over that instrumentation. And so it's either going to fail or I'm going to loosen the screws and I'm going to fall a little bit into kyphosis. And one of the nice things about this, and that's what we're going to talk about here just after me, was Bob Gaines and his group came up with the classification of when do you really need to go anteriorly. And so I'm not going to touch on that because you're coming up next, but that really gave us a good idea on how we should potentially look at creating an environment for surgical stabilization anterior columns. So here's the Bs, and this is actually at A4 that we're looking at, kind of a combination when you really look at it specifically. And we find that most of the time with those B fractures, they tend to be unstable with a angular deformity, so it's really pretty worthwhile to go ahead and stabilize those fractures. And so the C categories, those are all unstable. So you're really looking at at surgical stabilization with the Cs. And so, again, we started looking, what's the timing? What's the timing to look at these particular fractures? Oftentimes they're associated with the other injuries, so we have a tendency sometimes to delay that. It's either a head injury or an abdominal injury of some type. So the concept, we're going to fix it, but do you fix it immediately or do you fix it down the road? And so we developed a couple of ways to be able to stabilize things at. So this was one of the early concepts of actually reestablishing anterior column support by putting a cannula in and packing bone graft into that fracture. And that actually worked pretty well. Problem is most of the time the disc is disrupted up above that, so it has a tendency to fall into a kyphotic segment even after you reestablish that anterior column that's there. So here's the 2 up and 2 down. Works beautifully. Problem is you're tying up different segments. Is there a way that we can kind of manage things by minimizing the mobile segments that are involved with the stabilization? So we said, okay, let's go ahead and put the anterior column. Now we've supported it, but look at us. We're still doing 2 up and 2 down. So my goodness, why are we're not paying attention to things? We've reestablished the anterior column, but we're adding up 2 extra segments. So does that really make sense? Kiyoshi Kaneda had a very interesting conversation with him years and years and years ago, and he was kind of the same opinion. He said, why are we doing this? So he came up with the Kaneda system, which was a beautiful system to provide mechanical stability with the reestablishment of the anterior column. The problem is, if you ever did one of those, it was a nightmare to try to put together. You had screws going all different directions. You had these little wrenches that would always break. So it was just a mess. So I said, let's see if we can come up with something a little bit different to give us the same stability and make it a little bit easier on the surgeon. So we came up with a university plate, which was a locking plate anteriorly. And so Howard and I looked at this from the stability standpoint, and we found out that if you take a burst fracture, you can actually stabilize it from the anterior approach, doing everything from the front. And if you notice coming back one level up, one level down, not quite as stable, and this is going to come to when Rick Sasso and I looked at our data, of importance. So you can't really establish the stability with a single screw up, a single screw down over a burst component, okay? So biomechanically, that's the data is there. And so, like I said, Howard looked at the systems that were out there, had the Kaneda university plate, and Tom Zadeblik had created an instrument too, the Z plate. And so we put them in of course, the mechanical testing machines, and they don't lie to you. They give you the data whether you like it or not. And so we looked at all of them with the interbody spacers in, but all the same, gave you great stability. But I said, Howard, why don't we take the anterior column out and let's see if that particular systems will stabilize without that without that anterior column. And so that's what we did. And it turns out the Kaneda system and the university plate did very close to mechanically to the stabilization of the fracture. So we felt like we were on solid ground by doing an anterior approach only with these burst fractures, these unstable fractures. So kind of it was kind of stepping off into the abyss a little bit. But we our first 14 patients that we did, we looked at them really closely because are we going to fail on this thing? But we were very fortunate. It worked just fine, and this is a fracture dislocation that we had, and we talked about the contiguous fracture up above yesterday. If you notice, this is basically a split in 12. So if you're coming in laterally, you're from a standpoint of principles that we were talking about, I should be able to stabilize this T12 fracture just like I would a tibia fracture. I'm going to compress it. I'm going to put a screw all the way across and grab both cortices, and you get really nice stability with that, and it still gives you a nice platform. So what we did is and here's the T12, and then there's the burst component. So this thing is kind of smashed a little bit. But we found out, just like you were with a tibia, you can do the same kind of realignment with distraction, a little bit of rotation. We used a bean bag, and you give yourself a nice reduction component with these patients from an anterior standpoint. And then you do your decompression, your stabilization, and 6 months later, he's doing really pretty well. So we looked at these first 14, and that was really good. I talked to Rick Sasso, and he goes, said, I like what I'm seeing, said, but your numbers are small. He said, how about if I add some numbers on this thing? I said, okay. I said, are you doing this? He goes, well, I can. And I said, now that we've seen it seems to make sense. So Rick and I combined our numbers, and we published this in the mid-2000s. And we had 40 patients, and they were all Bs and Cs. And they were all treated with an anterior corpectomy, reconstruction, stabilization. And we followed them for, the average was 31 months. And what we found is that they all did remarkably well. They healed the anterior column. They had a complete decompression of the canal. And we were able to maintain that alignment long term. Now, getting back to that biomechanical study that I was telling you about, we decided to compare the anterior stabilization to the one level up, one level down. And what we found is that the anterior reconstructions maintained their correction, whereas if you go one up, one down with no anterior support, they all fell into kyphosis. But they still did clinically, they were okay. But from the mechanics standpoint, it makes perfect sense that you look at your numbers. And it did exactly what the biomechanics are saying. What those MTS machines were telling us was really true from a clinical standpoint. So did we validate the TLIX? Yep. When you look at this as early on, we've got a lot of data that we need to have supported, but the TLIX now is really starting with those options. We're finding that the suggestions of surgical intervention with the A, Bs, and Cs are appropriate. So the early studies, it shows that it's not only validating the system, but it's also giving us an idea of how we need to treat them. So what's the future? Welcome to the AI world. We got WebMD, we got Amazon, we got all of these things, we got telemedicine. And so, what we do is we've got this thing in our pocket. So send a letter of referral to Jens Chapman on Mr. John Doe for evaluation of a right perineal nerve palsy. And here you go. It's automatic. Comes right into that thing. It gives you your physical exam. It adds all that stuff in there. So Mr. Chat MD has just created me a letter to send to Jens for a referral pattern. We've got that technology out there now. So it makes perfect sense. Well, what about surgery? The STAR system now is doing bowel resections and reanastomosis with no human input. What's going to happen? Let's look at the ethics. Let's look at the liability. If you've got a robot operating, who's going to be liable? So now we've created a whole new scenario of what's going on. In a couple of weeks, we're going to even have a course here looking at robotic surgery. So I meant from the standpoint of the future, this is coming. And whether we like it or not, I always look back at Arnold Schwarzenegger. I'm afraid I'm going to get a knock on the door one of these days and I'll be back. But, I think we have to be cognizant of what we're creating. Even though we're making it straightforward, we may be creating some issues for ourselves. So, what are we seeing? It's going to be a very interesting process. There are notes in our letters and everything. We can do that right now. When you look at the scans, the AI capabilities of looking at a scan and telling you what the fracture pattern is there. It's just the large data that we have. Looks and combine that with the neurology process. So what's going to happen, AI will be able to select what surgery needs to be done, or if surgery needs to be done. The surgery can then be done by the robots with navigation without the humans involved. The beauty of this is now you've developed a global system that allows every fracture to be treated exactly the same, whether you're in North America, whether you're in South America, whether you're in Europe, looking at these large datas, so that the ability of the surgical procedure to affect the clinical outcome and disabilities is going to be the same. So now what you've done is you've decreased cost, because there's probably a lot of people that are being operated on that don't need to be operated on if you look at the data. And so this is going to be one of the things that I think we'll be seeing in the future with the AI-generated database. So are surgeons going to be obsolete? You know, are we putting ourselves out of a job? Who knows? I think we have to kind of get back to that really interesting discussion in Maverick. So he's sitting there after he's crashed his Mach 10 jet, and Kane's all interested in putting the drones back with no pilots, you know, and he says, Maverick said, your kind are headed for extinction. Maverick kind of goes out the door, turns, looks at him and says, maybe so, sir, but not today. That, my friends, we still have the gestalt. A robot doesn't have that gut. There's some things that we're doing from a surgical standpoint that we're in there. We can say, okay, I need to put a little bit more tight, a little bit more torque on that screw. Ooh, that's a little bit too much. Don't do that. You don't have that feel, that gestalt, or that reasoning for doing that particular procedure. Just like we were talking last night. You've got a guy that comes in, homeless, drug addict, all this. Do you operate now? Because if you know he's not coming back, that's a gestalt that we as humans have. You can't feed that into a system at this point. So we're not there yet. So fortunately, we're not obsolete. Let's have a good time for the rest of the day. Thank y'all very much.
Awesome. Wait, Bob, just one question. Super lecture, huge big picture perspective, just what we hoped for. I'll put you into my shoes. It was last night, this is real life, 2 a.m., and there's an outlying ER in the so-called Olympic Peninsula. This is way yonders. This is way out there. And there's a burst fracture in a 70-something-year-old. What would you like that doctor to describe this fracture? Which classification system in an ideal world at 2 a.m. would this doctor relate to you?
I want that guy to tell me I've got an AOC fracture with a neurologic deficit in a 70-year-old that has hypertension, atrial fibrillation. He's on, Lasix, whatever, all those. That's how I want that described. If you give me, I've got a C fracture, I know immediately that's unstable. I've got a deficit, so that's going to give me a real idea. I said, I tell you what I want you to do with that patient. I want you to put him on a helicopter or an ambulance and just send him on into the emergency room right now.
So this did not happen.
What? You mean with AI it didn't happen?
We're far from AI, and AO has not helped AI get further. We need the AO-AI system, or AI-AO, whichever takes the preeminence. We go through this endless soliloquy of whatever, and what always comes through is that there is a perception of, or the description of, a 3-column fracture that comes out. Fortunately, we are all digitized now, so I can actually look at the images, I can look at the medical record, I can see what's going on, and of course it's a person with drug abuse problems and all sorts of other deviations from the ideal norm health behavior. But why has this 3-column injury concept been so successful when pragmatic, globally studied, at huge financial investments, things like the AO system, has just not made it?
I think it actually is making it. I think it's just a slow process. And I think, that's the beauty of of these kind of, these conversations that we're having right now. I think when you look at the way, surgeons are trained in other regions, not everybody is trained within this particular set of norms. And so I think as we have the global implications of our education process, I think that's why we need to continue to have these kind of discussions on why are we treating this particular fracture in this way. And you have to understand the mechanics. Everybody talks about a burst fracture. What is a burst fracture? Well, a burst fracture can be an A, B, or a C. And so I think you have to look at the concept of stability, and I think that's not everybody is trained that way. Not everybody is trained in those mechanics.
Before we move on to the McCormick classification lecture, I just want to follow up on that. So, point A, is this something where we failed by not involving the radiologist first and foremost? Because certain things stick with them. Like to the present date, I get every posterior hardware labeled as Harrington rods. And I'm sure you have the same experience. Every posterior system is Harrington rods, furthest from it, but that's it is. And secondly, is machine learning not the logical answer to get to a consistent classification? We can train the digitized environment to kind of pick up on certain things, ask certain questions that are kind of meaningful. So should we involve the radiologist, and should we just count on machine learning in the future?
Yeah, that's exactly what's going to happen. I think that's where we've got enough data now that really proves that. And I think you are correct that we have not been instrumental in the training of radiologists. And because our group, I can remember I would get these things, and it was exactly like you said. Here's the reading. That's why I never trusted my radiology readings on a lot of these guys, because they hadn't had the training. So he'd come out with Harrington rods, and wait a minute, Harrington rods was 30 years ago. You're going to need to look at this. So what we did at the University of Mississippi is I had all of the interventional radiology guys come to one of our discussions. And so that really changed, and we went over the 3-column aspect of things with the training aspect of them, because they were training the radiologists of the future. And that seemed to make a difference. But I think the machine learning, and that's what we're really getting down. That's where you gather your data. And you plug all of these images in, they get read, and then you look and say, okay, this is this classification, this is this classification, this is this classification. And all of a sudden, then you develop this large data bank, and the machine has decided, okay, when I see this and I see this particular issue, I'm going to put it in that category. So I think that's extremely important. And I think that's where we're going. And I think that's what the future is going to be, is that when you come in and you've got a C fracture, that image is going to be assessed, and this is an unstable pattern. This needs to be fixed. It can be fixed with an anterior approach. It can be fixed with a posterior approach, or it can be fixed with it's going to still give you options till we get enough data that says, Dr. McGuire, you have a C fracture with a neurologic deficit. You need to go to the operating room now, and you need to fix it with an anterior decompression and a screw above and a screw below. That's what ultimately I'm going to hope in the future that we're going to have, and that's going to be a global implication when that happens.
Love it. Dr. McGuire, before I let you go, I'll impersonate the judge in NOLA. You're on the witness stand. You're under oath. Are there 2 or 3 columns in the thoracolumbar spine? There's only a yes or no. It's only 2 or 3. How many columns does the spine really have?
Judge, I understand what contempt is, and under duress, I'm going to answer from an anatomical standpoint that, yes, there are only 2 columns.
Yes. Dismissed. Thank you. So the stability question has already raised its head, and Dr. Ashraf Al-Naga